Welcome to the Endocrine Matters podcast. This podcast episode is sponsored by Complete Medicine and Hey Healthy. Welcome back to Endocrine Matters. I'm Dr. Arti Thangudu, endocrinologist, founder of Complete Medicine and Hey Healthy, and your guide through the science that actually matters for people living with diabetes and the clinicians taking care of them. Today, we are talking about something that has been generating serious conversation in endocrinology circles for years and is finally getting the broader attention it deserves: GLP-1 receptor agonists in type 1 diabetes. If you are a person living with type 1 or you love someone who is, you may have wondered, are these medications for me? Are they safe? Why hasn't my doctor brought this up? And if you are a clinician, you may have hesitated because of older, smaller studies that raised real concerns. Today, I want to walk you through what the data actually says because the landscape has shifted. I also want to be upfront about something. This is not me reading research from a distance. I have been using GLP-1 receptor agonists in my own patients with type 1 diabetes for years. I have watched what happens clinically, and what I have found and what the data is increasingly confirming is that these medications do things for people with type 1 that we simply had not had great options for before. Endocrinologists can sometimes be seen as cowboys in the metabolic space, and honestly, I'll take it. We move when we see major clinical signals as long as the risk is low. We used GLP-1 receptor agonists for weight loss in our patients well before they were FDA approved for that indication because we were watching it happen in our clinics over and over and over again. The same is true here. I am not saying that any provider uncomfortable with the complexity of type 1 diabetes and weight management should be doing this. You need an endocrinologist to navigate this safely. But for those of us who are in this space every day, this is not new territory. The evidence is just now catching up. First, a quick landscape, because I think context matters here. Over 2 million Americans are living with type 1 diabetes, and I want to say something directly. Type 1 diabetes is not a childhood disease. Children grow up. They become adults living with type 1, managing it every single day for decades. There is no good reason that type 1 diabetes should be life-shortening anymore, and yet the complications that drive mortality are still happening, and they are largely preventable. Globally, an estimated 9.5 million people have clinically diagnosed type 1 diabetes, a 13% increase since 2021. That number is climbing, likely due to a combination of improved awareness, environmental factors that drive autoimmunity, and the downstream effects of COVID on immune dysregulation. We are not talking about a small or static population. People with type 1 are at significantly elevated risk of cardiovascular disease and kidney disease compared to the general population. These are the complications that drive mortality, hospitalizations, and long-term reductions in quality of life, on top of the daily burden that already comes with living with this disease. So when we have a medication class that might meaningfully reduce those risks, we have an obligation to take it seriously. One more important framing point. GLP-1 receptor agonists, drugs like semaglutide and tirzepatide, are not FDA approved for type 1 diabetes. I want to be transparent about that. They are approved for type 2 diabetes and obesity. Their use in type 1 is off-label. What we have been missing is large-scale long-term outcome data. In 2026, that data finally arrived. Before I walk through the trials, I want to share what I have observed firsthand because clinical experience is part of the evidence base too. In my patients with type 1 and obesity who start a GLP-1, a few things happen consistently. First, they lose weight, meaningfully. Second, their time in range improves. Third, their insulin requirements come down. And that third piece is not trivial. Lower insulin doses can further support weight loss because insulin is a storage hormone. The GLP-1 receptor agonist reduces appetite, which reduces caloric intake, which reduces insulin burden, which then further supports metabolic improvement. We know now that GLP-1 receptor agonists work in many more ways than just making you eat less too. They set off a cascade that benefits multiple dimensions of their health all at once. This is what I see in my clinic, and interestingly, it is what the literature is confirming. Let me walk you through the full arc of evidence, because I think it is important to understand not just where we are, but how we got here and why earlier data is not the whole story. The first large-scale trials were Adjunct 1 and Adjunct 2, published in 2016, examining liraglutide in type 1 diabetes. These showed modest A1C reductions, less than half a percentage point, meaningful weight loss, and reduced total daily insulin dose. But they also raised significant safety flags. Symptomatic hypoglycemia increased by 20 to 30%, and hyperglycemia with ketosis doubled at the higher liraglutide doses. These findings put real brakes on clinical enthusiasm, and understandably so. But here is my read on those trials as an endocrinologist, and I think this is important context that often gets left out of the conversation. First, these studies did not require patients to be overweight or obese. The minimum BMI cutoff was 20. We were studying patients with type 1 diabetes who did not also have obesity, exactly the population least likely to benefit and most likely to be harmed by reduced insulin dosing. Second, insulin was reduced by 25% before randomization and by an additional 10% with each dose increase of liraglutide. For a lean person with type 1 who does not have much insulin resistance to overcome, that is a massive reduction and a recipe for metabolic instability. Third, these patients were not necessarily under endocrinology supervision. In my view, every person with type 1 diabetes deserves expert management of their complex condition. The expert for diabetes is an endocrinologist. And fourth, liraglutide, also known as Victoza, has substantially more nausea and vomiting associated with it than agents we use today. We stopped using it for good reason. And I would note the study investigators suggested that increased nausea may have prompted more ketone checking, which artificially inflated the apparent ketosis signal. I would go further than that. Nausea and vomiting from liraglutide could have led to dehydration and true DKA, independent of the GLP mechanism itself. Finally, and this one matters, these trials were conducted in 2016, when CGM was not remotely as available or sophisticated as it is today. I was treating diabetes in 2016. No CGM, no hybrid closed-loop systems. Titrating a GLP-1 receptor agonist alongside insulin in a type 1 patient without real-time glucose data is a fundamentally different and more dangerous proposition. I would not do it today without a CGM, and I don't think anyone should. The bottom line on Adjunct: it was the wrong patient population, the wrong drug by today's standards, with the wrong technology, and arguably the wrong insulin management protocol. The signal it generated was real, but not generalizable to how we practice now. Then came the Adjust T1D trial, published in the New England Journal of Medicine in 2025. And this one is far more relevant. The study examined semaglutide in people with type 1 diabetes and obesity using an automated insulin delivery system, a hybrid closed loop, the right patients, the right drug, and the right technology. The results: modest A1C reduction, improved time in range, which is a much more meaningful metric than A1C alone, and one we can now measure precisely. They showed marked weight loss, no DKA events, and similar rates of severe hypoglycemia between the groups, between the treatment and placebo. A small but important tirzepatide trial in adults with type 1 and BMI over 30 showed similarly compelling results. The science is catching up with what endocrinologists have been seeing in their clinics for years, and I think it is worth pausing on that. A lack of evidence is not the same as evidence of something not working. When a credible expert with endocrinology training, board certification, and genuine clinical experience carefully evaluates a patient, explains the mechanism, the known risks and benefits, monitors them closely on CGM with direct access to them to adjust insulin in real time, that is not recklessness, that is medicine. That is what we do. And now we have the data to support it. This is different from non-experts practicing without evidence and contrary to evidence who don't have the adequate knowledge and expertise base to practice beyond guidelines. Worse is influencer medicine that is contrary to evidence in the name of wellness, aka selling fear to sell potions, lotions, and online programs. Now let's go back to the data. In early 2026, two major real-world analyses took the conversation to another level. The first came from Johns Hopkins, published in Nature Medicine. Researchers analyzed electronic health records from approximately 175,000 people with type 1 diabetes in the US and found that GLP-1 receptor agonist use was associated with 15% reduction in major cardiovascular events and a 19% reduction in end-stage kidney disease, without any increase in safety concerns. That is not a modest signal. That is a substantial clinically meaningful finding in one of the largest T1D datasets ever examined. The second came from the Cleveland Clinic, a retrospective analysis of over 4,200 propensity-matched patients. This study found lower all-cause mortality and fewer hospitalizations and emergency room visits over 2 years among those using GLP-1 or dual GLP-1 and GIP agents, so like semaglutide and tirzepatide. Critically, DKA and hypoglycemia rates were similar between groups. They didn't have an increased risk of DKA or hypoglycemia like those 2016 trials. The last point deserves emphasis. The two fears that have historically kept clinicians from having this conversation, DKA risk and hypoglycemia, were not borne out in large-scale real-world data. That does not mean we abandon monitoring, but it does mean that the default clinical hesitation needs to be revisited. The risk calculation has changed. So what do we do with all of this? A few practical points for clinicians and for T1D families preparing to have this conversation with their doctor. Who is the right candidate? The ADA 2026 standards of care now explicitly support GLP-1 receptor agonist use for obesity management in adults with type 1 diabetes who have BMI of 30 or above through shared decision-making. Patients with cardiovascular risk factors, early kidney disease, high insulin requirements, or residual C-peptide production appear to derive the greatest benefit with the most favorable safety profile. Residual C-peptide is probably controversial because many patients with type 1 diabetes will not have that, but it is noticeable that people with residual C-peptide production appear to have better benefit because of the insulin production benefits of GLP-1 receptor agonists. Dose titration must be individualized. The escalation protocols from type 2 diabetes cannot be applied to type 1. Slower, more deliberate titration is appropriate, and proactive insulin adjustment is non-negotiable. In type 1, we need to understand insulin sensitivity and carb ratios and basal rates. As appetite suppression takes hold and caloric intake drops, insulin requirements will fall. We need to anticipate that, not react to it after the fact. In my opinion, CGM is not optional. Continuous glucose monitoring is what makes this safe and manageable in type 1. My own quality improvement research demonstrated that CGM access reduces diabetes distress scores, so this is not just a clinical safety tool, it is a quality of life intervention. If a patient is not on CGM, that comes first. Sick day and ketone management must be explicitly discussed. The DKA risk is not zero. It is manageable with structured education and proactive protocols. That conversation has to happen before initiation, not after a problem arises. And there are patients for whom this is not appropriate. Those with pre-existing gastroparesis may have worsening symptoms. Patients with significant hypoglycemic awareness need that fixed before we try a GLP-1 receptor agonist. And recent DKA or euglycemic ketoacidosis are concerns that we should discuss before initiating. This is always a shared decision-making conversation, individualized, informed, and carefully monitored. This is not a prescription handed out at the end of a 5-minute visit with a 6-month follow-up. That is not how this is done safely. If you are practicing in that type of environment, I do not recommend doing this. If you are a patient receiving care in that type of environment, I do not recommend doing this. The bottom line, the evidence for GLP-1 receptor agonists in type 1 diabetes has crossed a meaningful threshold. We are not speculating anymore. We have large population data showing benefits from using GLP-1 receptor agonists in type 1 diabetes when obesity is also present. We have meta-analyses across thousands of patients. We now have large real-world analyses showing meaningful reductions in cardiovascular events, kidney failure, hospitalization, and death. These medications are off-label for type 1. They require endocrinology expertise and close monitoring, but the data supports having the conversation and having it now. If you are living with type 1 diabetes or you love someone who is, and there are cardiovascular risk factors, obesity, high insulin requirements, or metabolic goals that aren't being met, bring this episode to your next appointment with your endocrinologist. Ask directly, is a GLP-1 receptor agonist something we should be considering for me? You deserve that conversation, and you deserve a provider who is equipped to have it with you. That is what being well-informed looks like. I'm Dr. Arti Thangudu. Thank you for being here. Subscribe wherever you listen, and I will see you next week on Endocrine Matters.